I'm Steve Glassman from the Leatherman Spine Center in Louisville. Today I had noticed that I was doing the talk. I feel much better about that. I'm going to talk a little bit about how this may apply to registries into databases. Those are my disclosures. I think, what we want AI to do is to translate data into information. And I think pretty much everyone in the audience knows how that works. It's by magic. Unfortunately, this is something that's pervading our lives that we know really relatively little about, and we just assume that it's going to work. But I think we can break it down to a little bit more manageable pieces that have it make more sense and give us a better idea of what it can do for us and what it can't, because in our data there are going to be some things that it's going to struggle with for a bit. So certainly this has the capability to manage large volumes of data. We've seen that in the previous talks. It's good at pattern recognition, right? It'll reproducibly identify similar data elements. And in fact, maybe what it'll do for us is recognize patterns that we previously didn't recognize. And that is, in a lot of things we do, a great potential. But the reality is this is a big data strategy that requires big data. And most of the data that we give it is little data, right? If we have a study with 20 patients in it, AI isn't going to help us do a better job with that. What we're going to need is granular data in high volume. And for a lot of the work we do, that's in fact not what we have. So if we think about the sort of analytic paradigm of what we want out of databases or registries, right? We want to identify a problem. We want to say what's the intervention, what are the short-term impacts, and then the relevant outcomes. And so for us, we can translate this to sort of, we have a diagnosis, we have a procedure, what are our complications, and then, right now we probably use health-related quality of life measures often as our outcome. And if you think about the data in each of those spaces that we're asking whatever AI paradigm to utilize, right, they're not very good, right? So in terms of diagnosis, what it reads out of the record is typically ICD-10 code, which is, notoriously bad, right? There are certain things we can identify, spondylolisthesis. That's why there's so many studies on spondylolisthesis, right? But, it doesn't recognize necessarily that it comes with a scoliosis or, is this really a stenosis problem, not a spondylolisthesis problem? And this is a really common patient for us. Patient with mechanical collapse, foraminal stenosis. It's one of our best surgeries. We do a TLIF. We make these patients better. You know what the ICD-10 code is for that? Well, of course you don't, because there isn't one, right? So how is an AI model going to go in and extract that case for us? When we get to CPT codes, right, what procedures do we do? You would think that's better. We're billing off it and reporting it, maybe more robustly. And there certainly are areas where that's good, but there are areas where it's not. An example would be, this is a patient with, foraminal stenosis who undergoes maybe appropriately a decompression, but doesn't work that well. And 6 months later, that patient has a revision. So it's fair that we get credited for we didn't choose the right procedure, or it didn't work out, and we call that procedure a revision. But in our present coding, this case where 7 years later the next level wears out, that gets called a revision as well, right? So spine surgeons are very disadvantaged because in hip surgery, if you have a hip replacement and 7 years later you need the other hip replaced, no one's calling that a failure of your operation. But we're unable to differentiate this in a way that we're able to protect the difference between I didn't do the right operation the first time and this is the natural history of the process. Complications, there are codes for a lot of these, and so that's something that could be pulled out effectively in a lot of cases. But there's going to be a lot of cases where it's a problem, right? Telling the difference in a database between planned stage procedures and an unplanned revision turns out to be really difficult. And unless the data is granular enough, AI isn't going to all of a sudden make data that's not granular. In terms of patient-reported outcomes, there's some things that AI might do. It can crawl different databases. So if data is held in a hospital EMR plus in an office database, maybe it can collate that data for us effectively. But probably it's going to get more effective as a tool when we get to measured outcomes rather than reported outcomes, because the reality is with reported outcomes, the problem is mostly getting the patient to do it, and AI isn't necessarily going to make that better. So while there's certainly a lot of things that AI isn't going to be able to do at this moment for us with our present data, there are, on the other hand, things that it can do, and the first couple talks have sort of highlighted a couple of those things, right? And we see it in JAMA every week, right? The large language models are going to be able to take data out of our op reports, which may be more granular than the CPT codes or the ICD-10 codes. Certainly it has the potential to reduce variability in reading of our x-rays and our MRIs, and maybe to extract PROs from multiple sources. But if you take this patient comes into your office and they have rheumatoid arthritis and stenosis and scoliosis and kyphosis, are they really going to be able to understand what that patient looks like in a way that lets them feed back to you data that's meaningful in your decision making? Well, there is a pathway by which AI undertakes these processes, and it's called labeling. Right? It's not that the program looks at a picture and for the first time understands what it is, right? Somebody goes in and teaches training the program things that it should recognize, right? So if you take this picture and you tell the program, this is a bus and this is a car and this is a person and this is a traffic light, and you do it enough times, then it'll absolutely recognize those things. But there's an advantage that we don't really have a disagreement about what's a car and what's a traffic light, right? But if you show this picture to 10 spine surgeons, there'll be 10 different opinions about what they're seeing there, what's stenosis, what's not stenosis. So training is difficult because it's not like we have uniform agreement about what we're identifying in a significant swath of what we do. This is a slide from the website of a company that does this labeling for a whole variety of industries. And this is their summary of how that works for complicated things like medicine and science. They said, we get domain experts who do the labeling for us. So, it'll pretty much work if we pick just one of you and you can label this for everyone because we know how much agreement we have among spine surgeons about what you're seeing, right? This sounds like it makes sense, but the application of this in both practice and then, belief in that it's been done appropriately is would obviously be problematic. So I'm going to show you a little bit about how ASR sort of is trying to poke at this and make it a bit better, right? So there are now 400,000 patients in ASR. It's a pretty significant size database. It's probably bigger than any other spine database. Some of that data, the data for which there are Vanguard forms, is labeled and a bit more granular, right? So these are forms where the doctor, many of you may have done these, fills out and says, why am I doing the operation? What is the diagnosis of the 11 things that are in the patient's EMR? I have back pain, I have stenosis, I have scoliosis. In the surgeon's mind, why is the operation being done? What are the symptoms it's being done for? What's being done at specific levels? What level was a revision? What level is, I just took screws out at that level because I needed to borrow the screw sites, but I didn't really do any additional work at that level. Things that are more granular than what we typically get out of our existing data. And this is an example of the smart form into the EMR at Duke. We also have it built into our Epic at this point. It's not completely widespread, but in about 20% of the ASR data, we have this additional data, and that's going to increase as we make that a required data element over the next year. This is a study that demonstrates that when you add the OR smart form to the standard registry data, it not surprisingly makes it much more accurate, much more granular, and therefore have greater utility. So in essence, what we're doing with that is we're crowdsourcing labeling. We're allowing the physicians that are doing the operations to say, what is it they're doing that procedure for? Will this be perfect? Probably not. But will it make it more granular and therefore more amenable to AA technologies? Probably so. So if we step back and think about what we want and what we've done to date, right? We want the right procedure in the right patient. We want to avoid complications, and we want to improve outcomes. But if you look at all the risk stratifying in smaller databases that we've done to date, really the thing we've done most effectively is to identify patients who are likely to have complications, and mostly what that is calculators that tell us don't operate on high-risk patients. Because frequently when this patient comes into my office, I say to myself, that looks like a good patient to operate on, and then the risk calculator tells me, no, maybe that's not. I'm just not sure how far what we've done to date has moved the ball down the road. Innovation, they told us we're going to have flying cars, but so far we have vacuums that spy on us. I think that in conclusion, AI is coming. We know it is. Spine data isn't really ready for AI. What we need is high volume data streams, and we need granular high volume data. So I think we need to do the work to make our data good enough that AI really adds value to it. Maybe eventually it gets good enough that it doesn't need our added granularity, but I don't think that's where we are at present. And I think that as we're trying to do an ASR, physician input may be a useful pathway to labeling to make that data more granular and better. So thank you.